pressure and what we can do as clinicians, seeing patients, to try to use this risk factor in a meaningful way to identify patients at high risk for glaucoma progression. So, we know from many clinical trials that have been conducted over the last 2 decades in glaucoma research what important risk factors are for the development of and progression of glaucomatous optic neuropathy, and include, most importantly, elevated intraocular pressure, but also reduced central corneal thickness, the development of an optic disc hemorrhage, and exfoliation are all very important risk factors for glaucoma development and glaucoma progression. You see that reduced ocular perfusion pressure was also a risk factor that was identified in the early manifest glaucoma treatment study. And as I mentioned earlier, a number of population-based studies have all identified low ocular perfusion pressure as a very important risk factor for the development of glaucomatous optic neuropathy in various groups of patient populations. What I'm showing you on this illustration are the relationship between the diastolic perfusion pressure and the proportion of patients that develop glaucoma from 3 different studies: the Baltimore Eye Survey, the Lale study, and the Projector VAIR study, done completely in different populations. And what's remarkable, looking at these 3 illustrations, is that they almost line up like a mirror image of one another. And if you look at what the tipping point, Joel likes the phrase tipping point, so I'll use that in honor of Joel. The tipping point is somewhere around 50 to 50 millimeters of mercury for the diastolic perfusion pressure. Now, my feeling is that even though the calculation of mean ocular perfusion pressure can be somewhat difficult, and I'll show you what is usually used in the calculation for MOPP, or mean ocular perfusion pressure, diastolic perfusion pressure is easy, and it's simply the difference between the diastolic blood pressure and intraocular pressure. So as an example, I mentioned somewhere around 50 millimeters of mercury for the DPP is an important thing to remember. Well, that might mean that a diastolic blood pressure of about 65 and an intraocular pressure average of about 15, so that if the diastolic blood pressure is below 65 in an eye with an intraocular pressure of 15, which is a very common intraocular pressure in our patients in whom we see progression, that might be a very meaningful thing to remember, that those types of DPP values, or about 50, in patients with a diastolic blood pressure is around 65 or less, could be something that is potentially actionable in our patients. So, how can we use OPP and how can we estimate OPP in clinical practice? I mentioned that a lot of the studies that I've illustrated, both during this presentation and the prior, have identified mean ocular perfusion pressure as an important risk factor for glaucoma progression. So what is MOPP and how can we calculate it? Well, it's 2/3 of the mean arterial pressure minus intraocular pressure. And if you see again that the calculation of mean arterial pressure is much more impacted by the diastolic blood pressure, 2/3 of the diastolic blood pressure plus 1/3 of the systolic blood pressure is used to calculate mean arterial pressure, then you see that diastolic blood pressure is a much larger contributor to the calculation of MOPP than is the systolic blood pressure. So as an example, a 10 millimeter change in diastolic pressure would ultimately translate to about a 4 millimeter change in mean ocular perfusion pressure. The same 10 millimeter change in systolic blood pressure would only account for a 2 millimeter change in mean ocular perfusion, but obviously the most important parameter here is intraocular pressure. And it's a one-to-one relationship such that 10 millimeter change in intraocular pressure will account for a 10 millimeter change in mean ocular perfusion pressure. But again, even though I'm highlighting how one can calculate mean arterial pressure, I don't think that this is the parameter that we as clinicians should focus on. There is a much greater degree of evidence surrounding the importance of DPP, or diastolic perfusion pressure, and it's rather simple. Again, just the difference between the diastolic blood pressure and intraocular pressure, and remember, 50 millimeters of mercury or less is the meaningful parameter to use in clinical practice. So, how can we do this in clinical practice? Well, there are different ways. One can obtain a seated diurnal office OPP measurement. That's a single measurement of the blood pressure at the time that we see our patients during diurnal hours, during waking hours, or we can calculate multiple office OPP measurements within a single day, very much like we generate diurnal intraocular pressure measurements within a single day. Or the poor man's diurnal curve is to calculate diurnal OPP measurements at different time points on different days, so that you see a patient sometimes early in the morning, sometimes in the mid-afternoon, sometimes in the late afternoon, with the idea that we know that IOP fluctuates not only in the diurnal but in the nocturnal period. And there are short and long-term variations in intraocular pressure. Well, there are short and long-term variations in ocular perfusion pressure as well. So by seeing patients at different time points on different days, one can get a sense of what that variability in OPP is over time. Now, the most robust method would be to calculate 24-hour blood pressure monitoring measurements. And we know that there is technology to do this. I actually have 4 different Welch-Allyn 24-hour ambulatory blood pressure measurement devices. They cost about $2,000 to $2,500. And we send our patients home with these in patients at very high risk or in whom we see glaucoma progressing at very low levels of intraocular pressure. And it is tremendously useful to see the magnitude of not only their diurnal, but more importantly, their nocturnal dips in blood pressure. The problem is that we don't have approved methods to measure 24-hour intraocular pressure right now in the United States. So we can't calculate 24-hour OPP measurements. The best surrogate that we have for that is 24-hour ambulatory blood pressure measurements. Well, I mentioned that there is very significant variability in intraocular pressure. We're very much aware of that. Factors that influence that variability include the methodology by which we measure intraocular pressure, the time of day, compliance with glaucoma therapy, and the types of glaucoma medication as well. Many of those same factors influence blood pressure. The methodology by which we assess blood pressure, either automated or manual measurements, whether we obtain the measurements in the seated or in the supine position, the time of day, cardiovascular disease, and medication. And as we know, glaucoma medication will also influence blood pressure values. So many of the same variable parameters that will influence IOP, why they influence blood pressure as well, and therefore they're both important to consider when assessing the OPP values. Now, many other miscellaneous factors, including caffeine, smoking, stress, will obviously also influence calculation of OPP values in the clinic. So that's how we do it. It's important to consider factors that influence OPP. Now, in whom should we be considering the measurement of OPP in our patients with glaucoma? Well, first and foremost, if you look at the evidence, it should be patients with open-angle forms of glaucoma. And those include primary open-angle glaucoma or high tension, including low tension or normal tension, and exfoliation glaucoma patients. These were patients that were enrolled and studied in the EMGT trial, in whom we see there is strong evidence that low OPP contributes to a risk factor for glaucoma progression. This is data I shared with you earlier showing that low mean ocular perfusion pressure in patients with normal tension glaucoma turned out to be a very meaningful risk factor for visual field progression, and intraocular pressure was not. It also turned out that low OPP was an important risk factor not just for visual function change, but also structural change. If we assume that the development of a disc hemorrhage is a surrogate for future structural change and future functional change, why we see that low OPP was also a very important risk factor for the development of optic disc hemorrhage in the same Logit's treatment study. Well, nocturnal blood pressure has been identified as an important risk factor for glaucoma progression for a number of decades. From the work of Hayray and others in Iowa, we know that those patients who have so-called normal tension glaucoma have a very high proportion of nocturnal dips in their blood pressure. And in this paper, Professor Hayray showed that those patients who had received topical beta blockers had an even greater drop in the magnitude of their nocturnal blood pressure, their heart rate, and were at higher risk for the development of visual field progression. And this may, in part, explain some of the results of the Logit's clinical trial, where we saw the very high proportion of patients that developed visual field progression in the group that were randomized to timolol treatment as compared to the group that were randomized to brimonidine. I showed you this data earlier, again showing prospective evidence that those patients with nocturnal dips in their mean arterial pressure by at least 10 millimeters of mercury greater than their diurnal mean arterial pressures prospectively were found to exhibit a higher rate of glaucoma progression than those patients without such nocturnal dips. So to summarize, I think OPP is a very important potential future treatment target for us to consider in patients at high risk for glaucoma progression. We should consider measuring OPP in patients with open-angle glaucoma, particularly open-angle glaucoma at normal levels of intraocular pressure. We should consider measuring OPP in patients who develop an optic disc hemorrhage because of the evidence that links these two together. We should consider measuring OPP in patients who progress at very low levels of intraocular pressure, particularly those who have a history of other forms of cardiovascular disease, including those with systemic orthostatic hypotension or who are using systemic or topical beta blocker therapy. OPP is an established risk factor for glaucoma onset and progression. It may be a modifiable risk factor and a treatment target in glaucoma. And what we all would like to see are easy and accessible and inexpensive ways to measure not only 24-hour blood pressure, but 24-hour intraocular pressure to provide a more robust assessment of the true ocular perfusion pressure within the eye. Thank you very much for your attention.